Hello, I'm Dan Vaena. I'm a medical oncologist at the West Cancer Center. I'm director of the GU program here at West. And I'd like to thank the organizers for inviting me to present this talk. We have a lot to cover about prostate cancer. Change the title a little bit to reflect the fact that we're going to be talking not only about new treatments for prostate cancer, but also management for prostate cancer as a whole, and the issue about the therapeutic sequences, which is becoming more and more complicated now. So we're going to talk about three things in this quick 15-minute update about prostate cancer. I'd like to discuss the ongoing issue about ADT intensification for patients newly diagnosed with metastatic prostate cancer, and how the advances in intensifying treatments in the last few years are resulting in better outcomes for patients. Also, we're going to talk about the entire field of PARP inhibitors, which is increasing very rapidly and expanding very rapidly in prostate cancer. And lastly, we're going to talk about PSMA imaging, which is a very new topic this year. So in the last few years, we've had several different trials that looked into the role of intensification for metastatic castrate-sensitive disease. The standard until a few years ago used to be to do hormonal therapy alone to lower the testosterone level to castrate levels to control the metastatic cancer. And several years ago, we had the initial presentation of the data with docetaxel, with the charted data, which included patients with high-risk disease with at least 4 bone metastases as an example. And then soon after that, we had all the different hormonal therapies that were typically used in the castrate-resistant setting brought up front and tested in upfront trials, intensification trials. And one of the first ones was abiraterone with Latitude, enzalutamide later with Enzamet, and most recently apalutamide with Titan. All these trials showed survival benefits and made patients live longer. And the most recent data is with apalutamide. It was just presented at ASCO GU a few weeks ago. And I'd like to cover that to highlight this topic in its current form. So with Titan, the design was very similar to all the other trials where patients had metastatic disease that was visible radiographically, typically by conventional imaging. They could have had docetaxel in the past, although it was not mandatory. And they would also receive standard androgen deprivation therapy. And then they would be randomized to either receiving apalutamide or placebo. The difference from some of the other trials was in the numbers of patients that would have had docetaxel before. Because it wasn't mandatory, this was different from trial to trial. And also the amount of metastatic disease would have been different from trial to trial. The earlier trials with docetaxel and Latitude would have required a greater amount of metastatic disease than Enzamet or the apalutamide trial. And basically, this trial showed a very significant overall survival benefit. In ASCO GU, we saw the follow-up overall survival data, the final survival data that with further follow-up at 44 months continued to be a very significant overall survival benefit. The interesting data that we got from this trial was also the notion about crossover. The question, is it that we're getting, the patients are getting apalutamide early, or is it that they're getting early versus late? So the question, is it early versus late, or is it that they're getting it at all at any point in the trajectory of the disease? And the first graph on the left is the comparison with the patients who were randomized to the placebo initially, but crossed over either at the time of progression or maybe crossed over at the time the trial was deemed positive and patients were unblinded. I'm not totally sure. But in any case, what this curve shows is that if you're not getting early, if you're just getting later at the point of unblinding, the outcomes was worse. That's the third line on the bottom. So this again shows and gives credence to the notion that getting early is very important. And that's what we currently believe for all these drugs, that it's the fact that you're getting early. It will give a better survival benefit than just waiting until patients have CRPC. The other very interesting point from these data is on the graph on the right about the second progression-free survival, that even after patients progressed on ADT and apalutamide and became castrate resistant and went on to have subsequent therapies, that the progression-free survival on the subsequent therapies was better if you had received apalutamide first. We don't really fully understand why that is biologically, but that's a very interesting point that again suggests the long-lasting benefits of getting intensification up front. So the ongoing questions that exist about intensification today are several. Because these trials had variable numbers of patients who received docetaxel, it wasn't mandatory. It was like docetaxel was allowed but not mandatory. There's different numbers of patients on each study that had docetaxel, and it's not a randomized, question to be addressed. So it still remains unclear if docetaxel is used, what is the additional value of intensifying with an androgen inhibitor. For instance, in enzalutamide in the ENZAMET trial, patients who received docetaxel seem to have no benefit of adding enzalutamide. But again, it was not a pre-planned question. So ARASENS is an ongoing trial with darolutamide. It's yet another anti-androgen that right now is FDA approved in the non-metastatic CRPC setting, but it's another upfront intensification trial that's being done. And in that trial, all patients are required to receive docetaxel upfront. And then they get ADT, docetaxel, and then they get randomized to darolutamide or not. So that trial, because all patients receive docetaxel upfront, is hopefully going to answer this question: is the addition of darolutamide to docetaxel beneficial or not? It may help us understand the relevance of docetaxel or not in this sense. The other question out there is for patients with non-metastatic disease but high-risk disease. So for instance, patients who have positive lymph nodes and get local regional radiation therapy with ADT, is there a role for intensifying those patients as well or not? Or patients who have a metastatic disease only by novel imaging. For instance, I have a patient who has metastatic disease only by PET exomin, but not by conventional imaging. So should that patient also be intensified with one of the novel agents or not? That's a question that we don't know the answer, because all these trials so far, they enroll patients with metastatic disease. There's a question about PARP intensification for patients with DDR abnormalities, and those trials are ongoing. And there's a question about prognostic factors. We don't fully understand who are the patients who might benefit better or worse, or who are the patients who are going to fare better or worse with those treatments. So SWOG 1216 is one of the trials with the CYP17 inhibitor that's investigational that shows an early hint of that. We had CTC data for CRPC, but not for CSPC. And that trial shows early that, in the early results, shows that CTC could be a discriminant of patients who might do better versus worse, even in that MCSPC setting. So we'll have more data on that in the coming years. Moving forward to PARP inhibition. PARP inhibition has become really very important in prostate cancer with the publication presentation of two important trials. One was the Triton-2 trial with rucaparib. That trial was a phase 2 trial and led to the approval of rucaparib based on response rates. And then olaparib has FDA approval as well. And that trial was published in the New England and had a survival benefit for olaparib for CRPC patients, metastatic CRPC patients, and also led to the FDA approval. This is the data with PROfound with olaparib, and in olaparib there were two cohorts, A and B. Cohort A was patients who had BRCA1, BRCA2, and ATM alterations, and cohort B was everything else. And cohort A was strongly positive for overall survival. The data is on the left, the graphs are on the left, and the hazard ratio was quite significant at 0.69 for overall survival. On the other hand, for cohort B, the data is more subtle. The difference in the curves is not apparent. The hazard ratio is 0.96 for overall survival. And so one of the very complicated questions that came out of PROfound is how to interpret the data on cohort B. There's a variety of other gene alterations that were pulled together for this cohort, and individual analysis for each individual gene were very difficult to do, and the numbers are very small. So it becomes very difficult to really understand what to do with cohort B. Triton 2, here's the data for response rates. This was a phase 2 trial with rucaparib and showed the 33% overall response rate in terms of RECIST criteria. That was by investigator evaluated population. And then on the right, you see on the top radiographic responses, on the bottom PSA responses. So again, significant activity and led to the accelerated approval. But there's many remaining questions with PARPs. The range of mutations is very broad. Like I said, some mutations were very underrepresented in those studies. So what's the difference between mutations, alterations in those genes versus functional testing for homologous recombination? We don't know the answer to those questions. The entry criteria for those trials was mostly based on gene alterations. The rucaparib trial, for instance, explored the question about BRCA mutations being monoallelic versus biallelic. We also don't fully understand the implications of those distinctions. Like I said, the relevance management of non-BRCA mutations, CDK12 is an example, often comes up in tumor board. It's very difficult to understand. We also don't fully understand the best sequence. The rucaparib trial required prior androgen inhibitors first, and then docetaxel to have been given. So patients entered the Triton 2 study after docetaxel and after prior androgen inhibitor, as opposed to in PROfound, prior docetaxel was allowed but not required. So really in practice, understanding what's the best sequence is unclear. A patient who had prior enzalutamide and now is progressing, would have several options in that framework. Would, assuming the patient has a BRCA2 mutation as an example, patient had enzalutamide progress, would have several options in that framework, either go on the alternative hormonal agent like abiraterone, or go on docetaxel, or go on olaparib. So we don't really have the data right now to understand what's the best sequence. Hopefully, there's more trials mature in that space, we're going to have a better understanding, but right now we don't. There's many other trials combining novel anti-androgens with PARP inhibitors. There's the question of germline versus somatic abnormalities, and we know the answer to that one already, that you should test for both. So both germline and somatic are relevant and result in response rates with those agents. And then again, there's a question of upfront intensification. It could be that in the future, we might be testing everybody for DDR abnormalities early on and using PARPs at that point and not later in CRPC. So lots of questions to get further understanding over time. And finally, we'll talk about PSMA PET. It's clear now that PET imaging with PSMA has greater accuracy than conventional imaging. Lots and lots of research on that and publication last year on the accuracy of PSMA PET prior to curative intent surgery. I'm not going to show the data, but it was more accurate. The problem is that long-term outcomes is lacking. So we're upstaging patients, we're finding more metastatic disease. What does that really mean in terms of offering them treatments that otherwise could be curable? And long-term data, we don't have that. It's going to take a decade to get that data. But the practical implications of this are going to be very, very huge. There's three different scenarios that I can see that could result in stage migration and could complicate our decision-making. The first one is patient selection for upfront local therapy. So again, is a better tool to understand who truly has metastatic disease and who doesn't right now. For instance, if you had a Lesion 9 patient, a Lesion 9 55-year-old man with a negative bone scan and a negative CT scan right now would go for prostatectomy and or radiation therapy. And we expect that PSMA PET is going to upstage some of those patients and prove that they don't have the localized disease anymore. So that's one scenario that is more straightforward. The second scenario, not so much. So patient selection for salvage radiation, a patient that had prostatectomy before, and now the PSA is rising, and there's a common question about salvage radiation. The tools that we have right now, the main tools are the stratification nomogram, a nomogram that takes into account PSA doubling time, surgical margins, a Gleason score, and so forth. And then, we have CT scans and bone scans as well, which are usually negative if the PSA is very low. There was data at ASCO GU this year that I'm going to show you on the role of PET PSMA on understanding a little bit better who should be an ideal candidate for salvage radiation. So that would be the second scenario where it could be used. And the third scenario is probably the most controversial, which is the patient who's already had prostatectomy, already had radiation therapy, and now has rising PSA again. And there's this question about, is there any role for any more salvage local therapy for oligometastatic disease? So typically in the past, this is a patient that would be started on androgen deprivation therapy at some point, either early or late, depends on how quickly the PSA doubling time is rising, depends on the Gleason score. But typically all that would be left historically would be hormonal therapy. But now this question comes up, if we find oligometastatic disease, is there any role for SBRT as an example? So for instance, if you pick up, if you have a patient that had prostatectomy before and then had salvage radiation to the prostate bed, and now PSA is rising, and you do a PSMA PET or you do an Axemin PET, and you find an isolated nodal relapse in the pelvis, is that patient curable with SBRT or not? So those are the real questions that are coming up with this novel imaging, and that we're starting to make those decisions for patients. But again, we're only going to have outcomes data in 5 to 10 years for these patients. So we're going to have to live for several years making those decisions, because that technology is here, but not exactly knowing if we're helping patients or not. And this is the data about salvage radiation. This was is a phase 3 trial that's ongoing. And this is the early data regarding the initial data on patients who get PSMA PET prior to getting salvage radiation therapy. So this is a randomized trial. Patients get randomized to either get conventional imaging with CT and bone scans, or to get novel imaging with PSMA PET prior to radiation therapy, when there is already a plan for radiation therapy. And what that data showed was that 20% of the time, lymph nodes in the pelvis were found, distant nodes 3%, bone lesions 8%, and the cancer was confined to the prostate 18% of the time. But about 20% of the time, there were lymph nodes that would suggest that the field has to be increased, and about 10% of the time, the picking up metastatic disease. And more importantly, this is the data that shows how often the radiation plans were changed based on the PSMA PET. And you can see in the control group with CT and bone scans alone, there was a change in the radiation plan in terms of changing the fields 26% of the time, as opposed to 57% of the time when PSMA PET was used. And the plan of entirely dropping salvage radiation, not doing it anymore because patients are felt to have metastatic disease, only changed 6% of the time in the control group with conventional imaging, but changed 21% of the time with PSMA PET. Again, does that mean that this is the right decision and that we're helping patients by avoiding salvage radiation because they were upstaged? We won't have an answer to that question for 5 to 10 years, but definitely that's what the data show. So my take-home message is there's a lot of things happening at the same time in prostate cancer. ADT intensification is the standard for metastatic castrate-sensitive disease right now. All patients who have metastatic disease up front should be intensified. There's several different options, and there's many ongoing trials to better understand the prognosis of those patients, predictive markers, and maybe the role of PARP inhibitors as an example. And and if they need docetaxel plus an androgen inhibitor or just an androgen inhibitor or just docetaxel. So a lot of activity going on. The second, PARP inhibitors are really here to stay. Clearly, they're active, but patient selection is often very complex, and very often, unless it's a BRCA mutation, very often those are molecular tumor boards where we're trying to understand really, is the patient going to benefit from this for a particular rare mutation or not? And then the sequence is a very common question I get asked in the clinic. When is the right time to introduce a PARP inhibitor? And it's difficult, as I showed. And lastly, novel PET imaging is very, very important technology that is really going to probably blossom this year or the next. Right now in very few centers in the US, but clearly a huge amount of potential, and definitely is going to lead to a lot of upstaging in prostate cancer and make us do very challenging decisions based on this novel imaging. That happens whenever new technology comes, new imaging technology appears, but this is going to be, the next few years are going to be very interesting with this. So I'm going to end here and happy to take any questions.